This meeting is being recorded. It's full screen in my laptop, ma'am.
It's okay, but it's not full screen with us. We can start the presentation it's 5 o'clock. Karpagam, is it okay we start? Karpagam? Vijaya madam is joining, huh? Karpagam?
Vidya join பண்றாங்க. Veena, Dr. Vidya is joining. சரியா கேட்க மாட்டேங்குது, பேசிட்டே இருக்கான். கொடுங்க. இல்ல அந்த அறிவியல் வெப்சைட் பேசுவாங்க.
So we shall start the meeting.
Hi, Meena. Good evening.
Good evening, Vijaya madam.
Yeah.
Good evening, Karpagam. Rekha ma'am. Good evening, ma'am.
Yes. Ma'am, நான் வந்து ட்ரெயின்ல வந்துட்டு இருக்கேன். சோ மீனா வந்து கோஆர்டினேட் பண்ணுவாங்க. நான் பெங்களூர்ல திரும்ப வந்துட்டு இருக்கேன்.
Welcome, Karpagam. Take care.
Yes.
Rekha madam,
Yeah.
shall I call again?
All okay, ma. All okay.
Rekha madam, call பண்ணவா? Sampath madam is on the way.
நான் பண்ணிட்டேன்ப்பா, நான் பண்ணிட்டேன். அவங்க வந்துருவாங்க.
சரி, I shall
அவங்க
start.
லாகின் பண்றேன்னு சொல்லிட்டேன்.
Okay, I will start.
Yeah.
So on behalf of the Obstetric Gynec Society of Southern India, I would like to welcome everyone for this wonderful webinar series, Vivaadham webinar series number 8, on an interesting topic, routine versus restrictive episiotomy. What is the clinical evidence and experience? On behalf of OGSI, the Obstetric Society, Dr. Sampath Kumari Madam President, myself, Dr. Meena Treasurer, Dr. Meenakshi Sundaram Treasurer, myself Secretary, along with our coordinators, Dr. Vijaya Ma'am, past President OGSI, retired Director IOG, Karpagambal Sairam, active Executive Committee member and marathon runner, environmentalist. And we have interesting speakers, Dr. Shirin from Kolkata and Payal from Hyderabad, and our expert Rekha Ma'am, who will be joining us. So we would just start the session. Can you just project the CV? Banu? Banu?
Meena, Meena.
Madam?
Welcome back to IOG.
Thank you, madam. I have taken IOG. Thank you so much, madam. First time going to work as a professor associate, madam.
Hi, Sampath.
Good evening, Meena.
Good evening, madam. Good evening. Welcome, Sampath ma'am. Ma'am, Sampath ma'am, few words, madam.
Yes, sir.
Good evening.
Vijaya, good evening. I welcome you all for this. Start பண்ணிட்டியா Meena?
Start பண்ணிட்டேன், madam.
I welcome you all for this Vivaadham series. I should thank Dr. Karpagam and Dr. Vidya for their coordination. Today we have about the episotomy, the speakers from Calcutta and Hyderabad, and our expert being Dr. Rekha Madam, our own Rekha Madam. We will have good take-home messages, I think. Now we will proceed with our scientific session. Meena, you can take off.
Yes, madam. Banu, can you project the CV, Banu?
Rekha ma'am is joined.
Madam, join பண்றேன்னு சொல்லிருக்காங்க.
Called her, I called her.
Already.
I already called her. She will join. She will join.
பானு அன்மியூட் பண்ணிட்டு என்ன அந்த ஸ்லைட்ஸ் ஷேர் பண்ணுங்களேன் பானு. பானு கேக்குதா? Sri Events. Who has joined from Sri Events, pa? Can you unmute? Sri Events ல யாருப்பா ஜாயின் பண்ணிருக்கீங்க?
சாகிதி இருப்பாளே மீனா?
இன்னைக்கு இல்ல மேடம், பானு தான் ஜாயின் பண்றாங்க. பிரியா கால் பண்ணாங்க இப்பதான். சாகிதி இல்லைன்னாங்க. Just now they shared the screen, but now they are not able to share.
சரி, அவங்கள நீ இன்ட்ரோ듀ce பண்ணிட்டு அப்படியே இன்ட்ரோ듀ce பண்ணிட்டு பிரசன்ட் பண்ண சொல்லு.
Yes madam, I'll start.
என்ன பண்றாங்க?
So we'll start with the interesting session on routine versus restrictive use of episiotomy. We start with the routine episiotomy by Dr. Shirin Islam, who's from Calcutta. Over to Shirin to just tell her expert comments on routine episiotomy. Shirin, you can project your slides and go on.
Yeah,
You
Shirin.
make her as a host, ma.
Okay, ma'am.
If you make
Thank you,
only,
ma'am.
she will be.
Yeah. Shirin has tried sharing already, madam.
Yeah.
Shirin, you can share your screen.
Yes, ma'am. I'm sharing my
We can
slides.
see. We can see.
Okay. Can I start, ma'am?
Yeah.
Sherin, you go to the slideshow.
Yes.
Okay, ma'am. Is it visible, ma'am?
Not full
It's
In
screen.
visible,
slideshow
but,
mode? I'm
no.
Not full screen. Make it slideshow.
it's a slides on my computer, ma'am.
Okay, just put that slide. Let me see how.
You can
Okay,
close
start.
and reshare, pa. Sherin, you can close the whole thing and make it as a
Okay.
small one. Make it again share screen and then click on that. You will get full screen.
Should I stop sharing or?
Yes, please stop sharing and then reshare.
Okay, ma'am.
Yes. Yeah. Now put full screen, no?
Yes, ma'am. Okay.
Yes, very good.
Is
Excellent.
it full screen
You can
now?
carry on.
Good.
Yes.
Yes, now it's visible.
Okay.
You can start.
Okay, ma'am. Thank you, ma'am. Good evening, all, ma'am. Before I begin today's discussion, I want you to imagine something with me. A labor room at 3 a.m. One nurse, one intern, one anxious family member, and a young primary cavida who has been pushing for 45 minutes, exhausted, scared, and trusting us completely. Yes, this is the scenario of childbirth in India. Not the polished textbook version, not the ideal Scandinavian midwife-led model. Our reality, with limited staff, high patient load, and a mix of trained DIs, nurses, and a junior doctors conducting majority of the normal deliveries. And in
Sherin,
those
your slides
crucial,
are not moving. Sherin, your slides are not moving.
Yes,
It is
ma'am.
in first slide. Now it is.
And in those crucial minutes, what we choose to do or not do can shape a woman's comfort, her confidence, her recovery, and sometimes even her dignity. That is why today's discussion is not just a guideline review. It is not about proving someone right or wrong. It is about understanding what is safest, what is practical, and what is human in Indian scenario. With that perspective in mind, let's explore this topic together, not as a debate, but as a team committed to safer births. Now, what is episiotomy? Episiotomy is a surgically planned incision on the perineum and the posterior vaginal wall during the second stage of labor to increase the vulval outlet. It is also known as the perineotomy. It is in fact the most common obstetric operation performed. There are two approaches, routine and selective. Episiotomy was first described by Sir Fielding Old in 1742. It gained prominence in the 20th century as a means of preventing uncontrolled perineal trauma and facilitating safe delivery. But with time, the guidelines agreed from routine episiotomy to restrictive uses. There are many types of episiotomy such as midline, modified median, J-shaped, mediolateral, lateral, etc. Historical basis for routine episiotomy. It was believed to protect the perineum from uncontrolled tears. In short, perineal body, permicavida with rigid perineum, scarred non-stretchable perineum, aim to preserve the pelvic floor function, thought to prevent long-term issues by protecting pelvic floor muscle, pelvic organ prolapse, urinary incontinence, helped obstetrician managed labor with better predictability. It shortened the second stage of labor, aid instrumental delivery, improve fetal outcome in certain situations, anticipated shoulder dystocia, large baby, inadequate maternal effort, anticipated fetal distress, persistent OP presentation, premature or low birth weight infants to prevent cranial compression. The most important thing is in favor of routine episiotomy is control. Clean control incision gives us better visualization, easy to degree perineal tear, whereas the spontaneous perineal injury can extend to any level, any depth, or can be ragged, and that was difficult to repair. It helps to protect the pelvic floor, prevents overstretching, may reduce the risk of long-term pelvic floor dysfunction, prolapse, incontinence, perineal laxity, preserves perineal support structure. When the forceps or vacuum are applied, the perineum is under immense pressure that can cause spontaneous rupture. To prevent that, routine episiotomy helps to increase the valval outlet, helps
कटलेट
to
कैसा आपला
apply the instrument smoothly and in smooth delivery.
കട്ട്ലറ്റ്
Hello?
നമ്മുടെ ആൾക്കാർ ചെയ്യണമെന്ന് ഓർമ്മയില്ല
It
കട്ട്ലറ്റ്
helps in
തട്ടിയ
rigid perineum
Can you
in
please mute
primigravida,
Banu, can you please
adolescent and postdated mother,
mute everyone?
imminent imminent third or fourth degree perineal tear, macrosomia, precipitate labor, inadequate maternal effort provide more space for safe and controlled delivery. It helps in shoulder dystocia, breech delivery, operative aesthetics, special circumstances such as malpresentation or twins. It helps in maternal comfort, may reduce prolonged perineal stretching pain, risk of deep uncontrolled tearing, allows quicker operative intervention, helps complete delivery faster in exhausted mothers. Fetal benefit. The second stage of labor is the most crucial for the fetal delivery. It helps to prevent, the routine episiotomy helps to prevent fetal hypoxia, fetal bradycardia, fetal distress by reducing the time, shortening the time of the second stage of labor. It reduces the cranial trauma, useful in during fetal distress where CTG is not available, or the one resident often manages to 6 to 10 laboring women. It has some surgical benefits. Clean straight incision. Straight incision is easier to stitch, predictable healing pattern, predictable depth and anatomy, easier wound approximation, better control over tissue planes, facilitates adequate exposure for perineal repair training in teaching hospital. The international bodies like WHO, RCOG, and ACOG recommend restrictive rather than routine episiotomy. Rate should be less than 10% ideally. Their emphasis is on selective use based on clinical indication, not universal application. However, these guidelines are based largely on settings with adequate staffing, continuous intrapartum monitoring, low workloads, immediate access to operative facilities. Many regions do not consistently have this condition. In Indian scenario, many births occur in primary health center. Deliveries are frequently conducted by staff nurses, A&M, trained DICE, junior doctors, not obstetrician. One staff nurse may manage 3 to 4 laboring women simultaneously. Obstetrician may be available on call but not in-house. Supervision is limited, monitoring is intermittent, patient turnover is high, emergencies often overlap. Perineal support varies greatly between providers. Training level among DIs and ANMs are uneven. There are certain evidence or studies that helps us to select the routine episiotomy over restrictive one. Thai multicenter RCT with 3006 women found no significant difference in severe perineal tear. Vaginal tears actually increased in the restrictive group. So restrictive isn't automatically safer. In several Indian studies in Kolkata, Gujarat, Baroda, no increase in third or fourth degree tear with routine episiotomy. Pain was higher, yes, but healing complications were manageable and perineum was easier to repair, especially for junior staff. Yes, but this has also some criticism and limitation. Increased postpartum pain, higher blood loss, risk of extension to severe tears, slower healing, dyspareunia possible, no benefit in preventing severe perineal tear, no improvement in pelvic floor outcomes, increased maternal mortality and morbidity. Global guidelines now favor restrictive uses. In conclusion, we can say that routine episiotomy is not outdated, it is strategic. It, it helps to prevent the uncontrolled tear and transform to a controlled one. Routine episiotomy has historical, anatomical, and practical reasons behind its use. While global guidelines favor restrictive use, the decision must be individualized and based on patient factor, fetal condition, labor room resources, staff availability, clinician experience. In many real-world settings, routine episiotomy can still play a valuable role in optimizing outcomes and reducing the preventable complications. Thank you.
Thank you so much, Sherin, for the very elaborate discussion on routine episiotomy. Was very clear, crystal
Thank you, ma'am.
presentation with lot of take-home points. Now I would like to welcome our next speaker, Dr. Payal Paharkar from Hyderabad, to enumerate points about restrictive use of episiotomy. We welcome Rekha ma'am.
Good
Payal
evening,
is from
everyone.
Good evening.
Fernandez
Yeah.
Hospital. Yeah.
Good evening. I'm
madam.
Dr.
Welcome,
Rekha
ma'am.
Kurian. Yeah.
Good evening,
Happy
Welcome,
to be
Rekha
here.
ma'am.
Yeah. I
Thank
hope.
you. Thank you
My
so
slide
much,
is
madam.
visible, ma'am.
Rekha madam, welcome.
Yes.
Thank you. Thank you, Dr. Sampath.
Yes, madam. Yes, we
Uh,
can start with
Yes. Yes, Payal, your slides are visible.
Yeah, sure, ma'am. So, good evening, everyone. I am Dr. Payal Paharkar. I am pursuing secondary DNP at Fernandez Hospital. Now I'm in the final year. Thank you for giving me such opportunity. First of all, greeting from Fernandez Hospital. Today I'll be presenting about the restrictive episiotomy under guidance of my guide, Dr. Siri. So here we start with. Already, madam has explained regarding the history of episiotomy. I'll just say after 1920, when there was a shift in the hospital deliveries, episiotomy has become a routine procedure. So routine episiotomy is a surgical incision which we give on the perineum for the delivery, easy delivery of baby's head. In certain countries, it is a routine procedure till date. Episiotomy is often linked to the urinary and anal incontinence and dyspareunia, though there is no conclusive evidence regarding proving this association with it. Selective episiotomy is only performed when the obstetrician considers it is necessary and it is as per the obstetrician's judgment. This is supported by various meta-analysis and literature, and also the American College of Obstetrician and Gynecologists also support this. Whereas meta-analysis also suggests that episiotomy does not lower the incidence of urinary incontinence, perineal pain, or sexual dysfunction. And it also does not protect against the pelvic floor injury. So there are various systemic reviews by Cochrane, FIGO, WHO, which support selective episiotomy that I will discuss in this slide. So, according to American College of Obstetrician and Gynecologist, the World Health Organization and Cochrane, they suggest that routine or liberal use of episiotomy should not be done. It is not recommended. More research is needed to inform in order to inform this policy in women where the instrumental birth is planned and episiotomy is often advocated. We need more researches for this. So it should be completely based on the clinical judgment of the obstetrician. Various authors has mentioned in their literature, in their publications, that restrictive episiotomy should be implemented. We should allow the labor naturally to gradually distend the perineum. We just have to sit there and do not do anything. So we studied up till now in our curriculum that indications of episiotomy like premature delivery, breech presentation, shoulder dystocia. Why we need that? In premature delivery to prevent the intracranial hemorrhage in the neonate. In breech presentation for the aftercoming head, smooth delivery. Fetal microsomia will cause shoulder dystocia. So in shoulder dystocia, to perform various maneuvers, we need a space. For that, episiotomy is indicated. In instrumental deliveries for non-reassuring fetal heart rate, in rigid perineum, when we suspect impending perineal tears, that time episiotomy is helpful. But all these indications of episiotomy are still in a debate. We need more studies, more meta-analysis, RCTs to prove this. Coming to the advantages and disadvantages. So, harmful consequences can be perineal pain associated with episiotomy, hematoma formation, infection, dyspareunia, healing complications, which all together leads additional burden on the healthcare system. But advantages of restrictive episiotomy can be lesser risk of posterior perineal trauma or severe form of perineal trauma, lesser blood loss, less need of suture material, lower frequency of postpartum perineal pain.
Banu, can you
It lowers
mute
the risk of
others,
perineal
please? Banu, please.
lower risk of perineal suture complications and less risk of dyspareunia. So there is a new legal term
1 minute,
talk about
Payal. 1 minute,
obstetric
Payal.
violence.
Yeah, who's having
Mahalakshmi madam, can you mute, please? Mahalakshmi madam, can you please mute your mic?
somebody's chatting Vishnu Sahasranam.
Mahalakshmi madam,
Where is Priya's party?
NS Mahalakshmi madam,
மீனா நீனே
NS Mahalakshmi
மியூட்
madam,
பண்ணலாம் நீயே மியூட் பண்ணு மீனா
control அவங்கள்ட்ட இருக்கு madam. Banu, Banu, Mahalakshmi madam, Mahalakshmi madam,
Talking over the phone, yeah. Where is
Banu, நான் பானு கால் பண்ணி பாக்குறேன் மேடம் ஒரு நிமிஷம்.
யாராவது ஒருத்தர் இருக்கணும்லப்பா லைன்ல. ஸ்டீவன்ஸ் மியூட் பண்ணுங்கப்பா. மகாலட்சுமி மேடத்தை மியூட் பண்ணுங்க. மியூட் பண்ணுங்க. ஸ்டீவன்ஸ் உங்க வீடா? Mute everyone.
பாருங்க எந்த இருக்குது
Okay, pa.
Can I start now?
Yes, yes, you can start, pa.
Yeah.
I've asked them to mute.
So coming towards the new legal term, obstetric violence. Obstetric violence is a routine episiotomy. It's now considered as a form of obstetric violence. And when we give episiotomy without an informed consent to the laboring woman, it is also considered as obstetric violence. As nowadays, couple are like more involved in the decision making regarding the process of labor, the procedure we are going to follow during labor, during delivery, post delivery. So informed consent has become an integral part of medical practice. So this all should be discussed during the antenatal period with the couple regarding the episiotomy and its advantages, disadvantages, and what is the selective episiotomy. So World Health Organization has given a statement that obstetric violence is a part of entrenched institutional culture marked by trivialization and naturalization of the phenomenon in a daily care. In June 2016 in California, there was a case, Turbin versus Abbasi. In that, doctor has performed episiotomy without taking a patient's consent. So court of law decided as a potential act of assault. So always we have to take a consent before performing episiotomy. This was regarding the selective episiotomy. Now I'll talk regarding the policy which we follow at Fernandez Hospital. So in 2007, we have changed our policy from routine episiotomy to restrictive episiotomy. In 2010, we introduced the midwifery services and the collaborative care of midwives and the doctors. In 2017, we have introduced the childbirth classes. We take regular audits and feedback regarding this, and any changes if required, we implement those changes according to the audits. So this figure suggests that episiotomy rate in normal deliveries at Fernandez. So we have reduced the episiotomy rate to 18.78% in 2021 from 75% which was in 2002. What helped in that? Routine use of episiotomy is converted into restrictive use. Then midwifery services, midwife collaboration, then various techniques to reduce the perineal trauma like perineal massage, birthing classes during the antenatal period, warm compression which is given during the labor. In spite of reduced rate of episiotomy, our rate of obstetric anal sphincter injury is still maintained between 1 to 2%. This was an audit performed amongst the midwives and the doctors regarding the rate of episiotomy. There was a significant difference between the two groups of episiotomy. Obviously, doctors' rate of giving episiotomy was higher, but in both groups, there was a decline of the episiotomy rate over the years. According to our study, the most common indication was the presumed fetal compromise. Rest indication will be like impending perineal tear, LGA baby, rigid or short perineum, shoulder dystocia, and previous history of OSC. In some cases, we have to give episiotomy. So what helped? Here, I'll talk about the different birthing positions and various techniques which we use to reduce the perineal tears. So there are some positions which help in reducing the severe perineal tear, which includes all fours position, kneeling position, standing position, side lying position. These positions will help in reducing the perineal tears as well as reducing the rate of episiotomy. Some position like semi-recumbent position, squatting position, and lithotomy position, they causes higher risk of sustaining severe perineal tears, and also they increase the risk of episiotomy. So at Fernandez, we usually favor different birthing position. We usually educate women regarding that during the antenatal period, so their mind will be prepared for that. Then coming to various techniques which reduces the incidence of perineal tears during antenatal period and during intrapartum period. So in antenatal period, we include childbirth classes and perineal massage. So childbirth classes we usually provide during the antenatal period to reduce their fear of the unknown persons, unknown places. Couples usually come together so they feel together more prepared for their birth experience. We educate them about the labor process, what positions we can use, how the process will be, how you can be comfortable in the positions, and what are the benefit of that. So their mind will accept regarding that, and they will be more willing to try all the positions. Second will be the perineal massage. Perineal massage we usually offer, and everybody should offer, from 35 weeks of gestation age. It is performed with the help of their partner, or the woman may herself may perform this. It is a technique which enables perineum to stretch at the delivery, and it reduces the incidence of tears. It should be performed in a U-shaped manner with the both thumbs kept inside the vagina. It can be performed twice a day. This also helps in reducing the perineal tears. This happens during the antenatal period. Then during the second stage of labor, when the woman gets contractions, that time we can apply warm compresses. So during the contraction, if we apply warm compresses, it helps to reduce the perineal tears. And this all the procedures, they're easy to implement as they don't require any great investment or any great gadgets. It just need learning and applying. These are the easy way to implement even in small nursing home also. So we should advise everyone to implement this procedure. We should learn about them so it will reduce the rate of episiotomy. So last but not the least, as the Hippocrates says, first do no harm. So it shouldn't matter who is birthing the mother. The only thing that matters is the mother and what is the best and safest for her and in agreement with her wishes. Thank you.
Thank you so much, Payal, for the excellent description of your practice of conversion from routine to restricted use of episiotomy. Now we welcome our expert, Madam Rekha Ma'am, who's past President Oxy and also MRCOG examiner. Over to Madam to enlighten us about the practices of routine and restrictive use of episiotomy.
Yeah,
Rekha Ma'am.
I had a presentation, but somehow I'm not able to.
Vice President Party.
அதெல்லாம் வேண்டாமா? Just that's enough. Yeah. Let's go on to the matter. So, I have actually an old presentation, but I don't know if I can load it on. From the phone, is it possible to load it on?
மேடம் if possible ஷேர் பண்றீங்களா மேடம் நீங்க
எந்த ஸ்கிரீன் போனோம்? That's what I'm just trying to see.
விஜயா மேடம் நீங்க ஷேர் பண்ண முடியுமா மேடம் உங்கதுல இருந்து லேப்டாப்ல இருந்து
அந்த இது
ஸ்ரீவன்ஸ்
எனக்கு
பானு
மேம் ஷேர் பண்றேன் மேம். எனக்கு சென்ட் பண்றீங்களா மேம் ப்ளீஸ்?
மேடம் எனக்கு அனுப்புங்க மேடம் ரேகா மேடம். எனக்கோ விஜயா மேடம்க்கோ அனுப்புங்க மேடம் ரேகா மேடம்.
I'm muted now. Hello.
Madam, we are able to listen, madam. You are audible, madam. Rekha ma'am.
Yeah, I'm audible. But normally there is that one place where I can share, no? Start video, audio. அதான் எங்க இருக்குன்னு தெரியல.
Send it to your mail and then.
மேடம் நீங்க லேப்டாப்ல இருக்கீங்களா மேடம் இல்ல செல்போன்ல இருக்கீங்களா மேடம்?
On the cell phone. On the cell phone, I've opened the this thing also, presentation also. Anyway, I think.
மேடம் நீங்க
ரேகா மேடம் ஹோஸ்டா மாத்தணும் மேம், அப்பதான் உங்களால பண்ண முடியும். ஹோஸ்டா மாத்துங்க.
Okay. ஹோஸ்டா மாத்தி.
ரேகா மேடம் ஹோஸ்டா மாத்ரியா?
எஸ் மாத்துறேன் மேம்.
ரேகா மேடம் ஹோஸ்டா மாத்துப்பா.
யா.
Okay. So anyway, I'll just talk even if the presentation doesn't come. We actually started the process of restrictive episiotomy in 2004.
மேடம் உங்களை கோ-ஹோஸ்ட் ஆக்கிருக்காங்க மேடம் ரேகா மேடம். நீங்க உங்கதுல ஷேர் ஸ்கிரீன் வருதா மேடம் செல்போன்ல?
I've got to go out of this and come in again.
இல்ல மேடம்.
இப்பவே வரணுமா?
இப்பவே வரும் மேடம். அப்படி இல்லாட்டி நீங்க எங்களுக்கோ விஜயா மேடம்க்கோ அனுப்புங்க மேடம்.
or else share me ma'am.
எப்படி ஷேர் பண்ண உங்களுக்கு தெரியுமா?
அதுதான் எப்படி ஷேர்
மேடம். மேடம் நீங்க செல்போன்ல வச்சிருக்கீங்கன்னா எனக்கு ஷேர் பண்ணுங்க மேடம். எஸ் மொபைலுக்கு நான் ஒரு ஹலோ மெசேஜ் போடுறேன் மேடம்.
இல்ல மேம் அவங்க செல்போன்ல தான் லாகின் பண்ணிருக்காங்க, அதனால கஷ்டமா இருக்கும்.
அதான் I don't know how to do it also.
திருப்பி போய் ஷேர் பண்ணிட்டு திருப்பி வரணும்.
இல்ல வேண்டாம், I will just talk அப்படினா.
அப்படியே பேசிடுங்க மேடம்.
That is better because I don't have the this thing to. So basically I think I'm totally in favor of restrictive episiotomy. And many of the things which were said as yes, we have busy labor rooms, we have to go to the OP, so many things in between. So we think that just giving an episiotomy will give us that extra 5 minutes. But is it fair to cut a woman like that when there is no particular reason? Okay, if there is a reason like you want to do instrumental delivery, forceps delivery, even vacuum delivery, we don't actually sometimes need if the baby is small. But if the baby is big and you feel there could be shoulder dystocia, then of course you can give. So if you do restrictive episiotomy, we were at 90% episiotomy for primies, which I think most of us, when we were learning, were taught that, okay, you are creating tears which are difficult to suture. I think maybe for the first years that is true. After that, once you've learned suturing and you have good lighting in your theater, even if the episiotomy, I mean, the tear that happens is little I mean, is irregular, we can still suture it, and it's actually much faster healing than an episiotomy suture. So the problem that we have is we have to educate and keep on whenever we have residents, our episiotomy rate goes up. So the registrars who come in, we between routine episiotomy that not use, we get away with an intact perineum, which makes us so happy. Sometimes even with a 2.93 kg baby, there is no tear at all, intact perineum. The patient is so thrilled with it. And now, as somebody said, women are coming with delivery requirements. I want to lie like this, I want to do like this. Those things are coming in, and soon that is spreading so much. We will have to comply with the patient's request. And therefore, I feel we should not do a routine episiotomy. Do when indicated. Just because you want to get away for the other delivery, I don't think it is a fair thing to cut the woman. We have managed to reduce our episiotomy rates from 90% to now around 35 to 40%. If we insisted more, I think it would reduce more. But sometimes when we have new registrars in, this happens that it increases. So we have not brought it down below to as Fernandez percent. Initially, when we were super enthusiastic, it came down, but then slowly it moved back up. Now we are at about 35%, around that plus or minus few. So I think, and we have not had that many problems with tears extending to the rectum or having a very bad tears. It is not there. So, I mean, I can't say that we've done a study. I had the full statistics up to 2015 to show, but I'm not able to show. But anyway, it was a gradual reduction. So, if the head of the department insists that it should be restrictive episiotomy, very slowly we can reduce it, because it takes convincing for the people in the department also to decide, yes, we have to do restrictive episiotomy. There is no need to cut. And sometimes there are tests which are a bit bad, where an assistant may have to come in and help. I agree. But most of the time, it is not bad. That is what, that we have to get into head. We've read in the books that it is going to be bad tear, and therefore we just straight away do a straight cut and think that that is helping the patient. But the pain and the suffering is much more in those cases. So if you do restrictive episiotomy and suture in a continuous fashion, where we don't have ends and tips of the episiotomy threads poking the woman, then I find that the patient is much more comfortable, and we can help the woman with her, especially they are asking for demands that we should not cut unless needed. People don't even want ARM unless needed. So that extent people are going, let the membranes rupture itself, unless you have a bad deceleration. So with these requirements, we must, I think, comply by some of the patient's requirements. Everything cannot be. But I think this is a very good practice which was started in 2004. And slowly, if we do, I think we can manage to restrict the episiotomy. Many of the reasons which the first doctor had said, it's true that busy episiotomies, etc. But I think with better labor room care and Lakshya and all that coming in, I think we have more doctors taking and attending to each patient. So just that we don't have enough personnel should not be the reason to cut a patient. If she's had previous anal sphincter injuries or some other incontinence problems, then of course we could try. In which case, or she's had a N fistula before, then totally she can even avoid a normal delivery, because you don't want to have another fistula and trying to heal it, etc. So I think those are the choices that we should be left with. So the movement started in, I think, 2000 or so, and it has spread worldwide that restrictive episiotomy is to be done. And also, we know that the Tamil Nadu government, I think Dr. Sampath Kumari will be able to enlighten, and Dr. Vijaya, whether that is what the government of Tamil Nadu has told the doctors. But to put it into effect, I think it is taking time, is my opinion. Can Dr. Sampath Kumari or Dr. Vijay enlighten us on this? Hello?
Yeah, I'm here, Rekha. Good
Ah,
evening. Yeah,
good
the
evening,
thing
Vijay.
is, the Lakshya, according to the Lakshya guidelines, It says
Yeah.
indicated episiotomy.
Yeah.
Rather than restrictive, it was an indicated episiotomy.
Yeah.
But I don't think we are able to follow 100% on that, especially during instrumental deliveries. I was seeing
Yeah.
a girl from Fernandez. She didn't put the indication of instrumental deliveries. That we make it as a must, whether it is
Yeah.
a room or a outlet. We
Yeah.
definitely do an instrumental delivery. And how in
Yeah.
Fernandez they are not doing. I just have to have a clarification on that. Whether she missed that point or not, I don't know. But
Yeah. Another thing which I would like to say,
lateral
Vijaya.
vaginal lacerations were more, Rekha. When we are not giving episiotomy, lateral
Ah.
tears were more. It was not a controlled tear. That is a little problem we are facing. We are not into 100%. Sambat can take
Ah.
also. Yeah.
Yes, madam. But Rekha madam, since your hospital, they are
Yeah.
able to do everything. But our
Yeah.
hospitals and the government set up so many deliveries. Their
Ah.
LSCS rate is also reduced. Episiotomy is also reduced. It
Yeah.
is mainly with the one-to-one care, madam.
One-to-one care.
Always it
That's why
is.
I'm saying.
Uh,
With Lakshya
it is
and all
not.
that, that one-to-one care may be a little better now. Is it
Uh,
in with Lakshya? I don't know. One-to-one care.
yes. One-to-one care because of the heavy. As you say,
Mm.
it is not fair to cut the women's episiotomy unless it is not needed.
Yeah, exactly.
Anyway,
So
we will try to do that.
I
Also,
think we have to try to reduce.
different positions we are not able to. PGs are not comfortable in delivering in all fours and lateral. All those things maybe with the midwifery already in KGH. We should learn those part of the thing. We are always lithotomy and comfortable and giving proper support and doing. We all are trained like that. The different positions we are not comfortable.
No,
But
we are
Rekha
also
madam,
not
after
using.
admiring your hospital, now in my college, we have
Yeah.
only hardly 45 to 50 deliveries per month.
Yeah.
Here the LSCS rate is also reduced, episiotomy is also reduced. Here our
Yeah.
LSCS rate is 31%.
Fantastic. So that is
Mm.
how we insist on it, and I think one of the things which worked for us was having an audit every Friday and
Yes.
talking about it. So talking, each person who comes in realizes that they have to restrict their episiotomy. So I think if you talk about it, people are willing, they understand, and then they reduce. But if otherwise, what usually happens is the senior midwife who's there is the one who advises. So they will tell you, just cut and finish off, madam. We have the other delivery to go. And then the registrar who's just joined doesn't know what to do. And then it just goes on. I feel
Now in
if
the
we,
teaching hospital, only PGs, madam, not senior. Only PGs in the teaching
midwives.
hospital. It may be in some
Okay.
headquarters hospital. Anyway, we can try to follow
Okay.
as you say, madam.
What about
That is
perineal
better.
massage, Rekha? Perineal massage, are you giving? She was telling you shaped.
We are not actually. No, this is all very good, but we are not doing perineal massage, nor are we doing any abnormal, I mean, different positions. We
Okay.
are doing the usual lithotomy, the usual thing which we were all taught, we are continuing. Some few patients who have demands that they want to deliver on all floors, maybe one in 3 months, one in 4 months, we sometimes, and that too, I will not agree to do it. The younger generation sometimes agree to do it. Otherwise, we are doing lithotomy, but in spite of that, we are able to control it at 30 to 35%.
Yes.
So, which I think we can do if we make up our mind and do it. And then patients are very much more happy if you can tell them that we will not cut. If it tears by itself, it tears. And we are not worried about lateral tears. It's not happening to the extent that we have been, that fear has been put into our head that it happens. It doesn't happen that much because we are not
But
forcing, you
yes,
know.
madam, it is horrible for this episiotomy pain rather than LSCS pain. Not
Yeah,
able to
exactly.
say 15 to 20
Yeah,
days. It's so
yeah,
horrible.
exactly.
Okay, thank you so much, madam.
Thank you.
We
I'm
should
sorry
have
I
a
couldn't upload that video.
Maybe you could
yes.
share later, ma'am. We can all see, no? In this video.
If possible, we
Yeah.
can get it from madam and present in some other meeting.
Yeah. I don't
Thank
know
you.
how to send it also now, so I'm totally stuck.
Mm.
Tarun should do it.
Ah,
Yeah, Tarun is not here. I'm in actually Kasiranga resort, sorry.
Oh,
So,
okay, madam. Enjoy, madam. All good speakers,
okay.
and we had wonderful expert comment
No,
by Rekha,
I
madam.
think it's very good that you all brought this topic up, and periodically bringing these topics up only will induce people to, change the practice, and then it makes a
Yes.
big difference overall. I think so.
Thank you.
Thank you so much.
Yes, Vijaya will
Thank you.
formal vote of thanks.
Yeah. On behalf of Oxy Medical Education Committee, and which is doing a wonderful job of, and this time the Vivaadham is really short and sweet and to the practical points. It's not like a CME or a lecture on one topic from top to bottom. It is nothing like that. Just whether to do or not to do, and one expert will come. And this is one of the good take-home points for the PGs and all the young junior consultants who are going still into the obstetric practice. And I would like to thank everyone for logging in, and I would like to thank Karpagambal and Meena, and of course my dear Sambar, and also Shri Evans for giving us the platform. Thank you so much, all the viewers.
Thank you, Sherin, and all the speakers and the Rekha madam. Thank you, madam.
Yeah, of course, the speakers.
Thank you, Vijaya. Thank you. Yeah, thank you, Meena.
Yeah.
Thank you, Sampath.
Thank you.
Thank
Thank
you,
you,
madam.
Vijaya
Karpagambal.
ma'am,
Good night.
Karpagambal.
Good night.
Thank you,
Enjoy,
Sampath
madam.
ma'am, Rekha ma'am.
Okay, bye,
Good night.
bye, bye.
Thank you, Sherin
Thank
and
you, bye.
Payal. Thank you,
Thank you,
Shri
ma'am.
Evans, and all the delegates who have logged in. Thank you so much.
Thank you. Thank you.
Come on, ஆளாளுக்கு சொல்ல போறாங்க இந்த ஷேக்கு இந்த பயாலஜி எல்லாரையும் வந்து